Thank you for joining CHRC today for our very special health education event. This event is a collaboration between Community Health Resource Center and CPMC Breast Cancer Care Team. My name is Twin, and I am the Community Health Resource Center's program coordinator. We are a nonprofit that has been serving the San Francisco Bay Area for over 30 years. We have 4 primary areas of service: nutritional counseling, mental health services, health screenings, and health education. If you are interested in appointments, please email me at the address on the screen right now. I'd like to pass things along to Dr. Ann Peled. For those of you who were here last week for our breast health lifestyle screening and early detection, Dr. Peled was here sharing a discussion with another women's health expert, Dr. Ricky Polikov. And today, Dr. Peled is back with members of CPMC Breast Care Team to provide you with a series of presentations, and she will also be moderating today. Thank you.
Thank you so much, Joanne, and thank you everyone for joining us today. We're really excited to have so many of you on for this presentation from our breast health team. So my name is Ann Peled. I'm the co-director of our breast cancer program here at CPMC and also a plastic surgeon and breast cancer surgeon. For those of you who may or may not be aware, our breast health and breast cancer program is really centered around our breast health center here at CPMC. Dr. Bokelman, one of our radiologists, is going to be speaking more about this, but it's actually the largest breast imaging center in Northern California, with over 44,000 imaging exams and procedures per year. So I think we really set the stage for our comprehensive breast cancer program and breast health program with our breast health center. The program itself is multidisciplinary. We'll talk a little bit more about that, but has extensive support services and resources for our patients, from everything from initial screening through breast cancer diagnoses and treatment. There's a real focus for our program, and particularly through the CHRC, as Twin mentioned, on community outreach and education. So we hope after this talk today, if any of you have other ideas for programs or topics you'd like us to cover, please let us know, because I think all of us really love educating and are happy to talk about any topics that would be relevant. In terms of our patient care pathway here at the Breast Health Center, I just wanted to highlight this. For me, I think this is one of the most unique and helpful parts about our program, is really making sure that we're taking our patients through the entire spectrum of care they may need. So we start with risk assessment and screening, talking about screening mammography. All of our patients go through a risk assessment as part of their screening studies. And then when we identify high-risk patients, then they're referred on to other treatments, which may include genetic testing and counseling, which you're going to hear more about from Elizabeth, our genetic counselor. Moving on from that to diagnosis, if women do need biopsies, needle localizations, we're able to do all of that, from everything from mammographic to ultrasound to MRI guided biopsies. If patients do have a diagnosis of a high-risk lesion or a breast cancer, their nurse navigator really coordinates their entire care going forward and gets them set up with the appropriate team members to continue on with their treatment. We have a multidisciplinary tumor board that all of us on the call, and another large team of surgeons, radiation oncologists, medical oncologists, genetic counselors, radiologists, pathologists, and other members of our support services. We all get together every week. I think this really helps make sure that our patients are getting the most comprehensive view of their treatment options. We talk about clinical trials, of which we have multiple clinical trials available, and it really helps us get our patients on the right track. Moving on to treatment, we do have all of the different subspecialties that would be involved potentially in patients going through breast cancer treatment here at CPMC, and also, again, numerous support services from nutrition to social work to physical therapy to lymphedema treatment, and even further than that. And then finally, I think another unique part of our program that's run through our nurse navigators is the ability to provide survivorship care. So for many people, they get through breast cancer treatment, but they don't really know what are their next steps. How often do they have exams? Do they need further imaging? What does that look like? And we're so lucky to have our nurse navigators set that up for patients so that they have a comprehensive written treatment plan for themselves, and that also goes to their other providers. So moving on today to our program agenda, we will have Dr. John Bokelman, who's one of our breast radiologists and co-directs our breast imaging program, be speaking about advances in radiology. Have Elizabeth Carte, who is our genetic counselor. She does a range of different cancer specialties, but we'll specifically be talking about breast cancer today. Dr. Joanne Edquilang, who is one of our newest members to our team. She is a breast surgical trained surgeon and will be talking about advances in breast surgery. And then Dr. Jeske, who's our medical oncologist specializing in breast, among other types of oncologic care. And she will be talking about tailored treatment in medical oncology. In terms of questions, if people have specific questions for everyone's talk, feel free to put them in the question and answer, as Twin mentioned, and I can help moderate those afterwards. All of us will also stay on after all of our talks to be available for a panel discussion for broader topics. I wanted to make sure to thank our sponsors. We're really lucky to have a great group of vendors who are supporting our breast cancer and breast reconstruction efforts, including Allergan making Nutrell implants and other breast reconstruction products, Prelude DCIS testing, which helps with our patients with DCIS think about next steps, Sientra, which specializes in breast implants for reconstruction and augmentation, and the team from Axogen, which does resensation, a novel technique for improving sensation after mastectomy. And the last topic, for those of you who may not know, today is actually Breast Reconstruction Awareness Day. And so that's why we picked this day. It's something that we have done for several years now at CPMC, really trying to focus on a national campaign through the American Society of Breast Surgeons about the importance of breast reconstruction and building awareness. Many people are uninformed about their reconstruction options. They don't know what they might be. They're not necessarily referred to specialists. And we see major disparities in access to reconstruction related to race, ethnicity, and socioeconomic factors. So the goal of Breast Reconstruction Awareness Day is really to let people know that there are options, whether it's lumpectomy or mastectomy, or choosing not to have reconstruction and to go flat after mastectomy. All of this is part of Breast Reconstruction Awareness Day, to know your options. Many people also don't know that coverage for breast reconstruction is federally mandated. So you do have access to breast reconstruction if that's something you choose. And to learn more, you can go to plasticsurgery.org. So I would like to thank all of our speakers. I would like to thank Twin and Janelle so much for helping coordinate today. And we will move on to Dr. Bokelman's talk.
Thank you very much for giving me the opportunity to share with you an overview of the advanced imaging technology that we've acquired and will start using very shortly in just a few months when we move the Breast Health Center to a new home. We're scheduled to move over to the CPMC Pacific Heights Outpatient Center on Buchanan Street in January, which is just 3 months away. And this is the newly renovated building that used to be the Pacific Campus Hospital. And we'll be occupying the same site as the radiology department used to inhabit prior to the hospital moving to the Van Ness campus last year. So in addition to the completely remodeled facility, we will have all new state-of-the-art breast imaging equipment. And this is due to a generous funding by the Philanthropic Foundation. This is kind of a list of equipment that we're getting that's all brand new and the latest technology. Just a high overview. I'll just do a quick review as we get into them. But you know, the big advances were there's been a recent advance with 3D tomosynthesis. Breast tomosynthesis has been out for several years now and has been widely adopted throughout the country. What we have here is kind of this latest generation. It's high resolution 3D imaging due to kind of advances in detector technology and algorithm processing. So we all of our new mammography systems will have that. And then behind the scenes, there's a lot of 3D image data processing that is necessary to kind of help, this has been brought on board. Basically, it helps us improve cancer detection, and it also aids in the network flow and image story of these very large data sets. Then also kind of a final one with these, we have advances in stereotactic and tomosynthesis guided biopsy systems that will it leads to an accurate, shorter biopsy time, which means kind of a more comfortable experience for the patient, and also aids us in sampling kind of the most challenging lesions that or in challenging locations that we're faced with once in a while. Because we have this new technology and we find subtle lesions, we have to be able to find that when we're trying to sample the lesion. In addition, the remodeling project was quite extensive, and without the funding from the foundation, we would not have been able to upgrade our already very good imaging equipment to this latest technology. And I'd like to acknowledge and thank them for that very generous support. The combination of having all this new equipment in this brand new remodeled facility is very exciting to look forward to. So before I get into the new imaging technology, I'd just like to touch on the scope of the clinical concern that we're focused on and the mission of early breast cancer detection and decreasing deaths due to breast cancer. Breast cancer is the most common cancer diagnosed in women. It accounts for 30% of all new cancer diagnoses in women. And there were we're anticipating approximately 331,000 new cases of breast cancer in 2020. The lifetime risk for women is 1 in 8 women will develop breast cancer at some point in their life. Thankfully, due to new treatments, early diagnosis, a variety of things, it's not a severe diagnosis or a death diagnosis. Although we did have nearly 42,000 women die of breast cancer in 2019. There's nearly 3.5 million women living with the diagnosis of breast cancer. That's based on 2016 data. And just to bring it to a more local level, here in the CPMC BA Breast Health Center screening program, just last year we detected 178 asymptomatic breast cancers through the screening program. To be in the screening program, there's no palpable lump, there's no symptoms. So these are not high-risk women, and 178 cancers in a one-year period of time. That certainly will impact, downstream, be a very positive impact on many women's lives. We know that better outcomes are directly linked to breast cancer screening, and early breast cancer detection results in early treatment with improved outcomes. In other words, fewer deaths from breast cancer. And thanks to the generous support by the Philanthropic Foundation, the Breast Health Center will have the tools to keep at the leading edge of early breast cancer detection and saving lives. So just on to the new equipment that we've managed. The backbone of the department is mammography. We have, as Ann mentioned, we have all modalities available, mammography, breast ultrasound, breast MRI here. But the core of the department is digital mammography, and we're getting all brand new high resolution tomosynthesis units. And both these all will be used for screening and diagnostic work. And they all have both 2D digital and 3D tomosynthesis functions. Excuse me here. So, pardon me. Yeah. Just a quick overview of the improvements in this system. The first improvement is improved patient comfort. And this system comes with a very neat curved compression paddle, a compression paddle system that kind of mirrors the natural contour of the breast and kind of compresses the breast in a more evenly distributed weight across the breast. So it results in significantly less discomfort. Unfortunately, mammography is uncomfortable to some women. We need compression because that stops from motion artifact, and it also helps limit summation densities. Both of those can obscure very subtle cancers. So the breast does unfortunately need to be compressed. This is a solution to that. And in a pretty large study that surveyed women that had previously had moderate to severe discomfort on mammography. Over 90% of women had a much improved experience with this system. So hopefully that translates to our findings once we start using this here in a couple of months. Also, probably the largest improvement in this machine is the high resolution tomosynthesis capability. It is, it's about not quite double the resolution, but it previously this was a 100 micron resolution, and that is now down to 70 micron resolution with this new study. Those are just numbers, but that translates to a much crisper, larger image that allows us to see kind of very subtle findings. And this is done with the same low-dose radiation exposure, and that's due to improved detectors. So, and then number 3 is these machines are able to synthesize a 2D image. 2D mammography is, everybody who has mammography has to have a 2D mammogram because 2D mammography images detect and characterize calcifications better than tomography does. So that is required. When tomosynthesis came about, adding this, it's basically an add-on study. It requires an additional exposure. And, you know, as you've probably heard, 3D mammograms are more accurate than conventional 2D. They detect, 20 to 65% more invasive breast cancers. That ranges towards the higher end in the more dense breast tissue. In women with fatty breast tissue, tomosynthesis still does detect small cancers that aren't seen on 2D, but it's less common. But anyway, the synthetic 2D image that this machine is now capable of doing is capable of replacing just a standard additional exposure of the 2D. So by doing this, we can limit radiation, and the overall exam, both the 2D and 3D exam, is just minimally more than what a standard low-dose digital mammogram exam is. So just a quick review of 3D tomosynthesis. A 2D image is a full thickness of the entire compressed breast. And 3D tomosynthesis images is a data set made up of kind of multiple low-dose images of the breast that the computer reconstructs and presents those images in 1 millimeter thick images for the physician to scroll through while looking for abnormalities. And the difference being a 2D image of the breast is just one view. A 3D image is actually comprised, if the breast compresses to 60 centimeters, there's 60 images on just that one view to scroll through. So it's a significantly increased detailed exam. Hard for me to show that in real time here, but it is an improvement. Tomosynthesis was developed to solve the problem of overlapping summation densities, which become more problematic in the, women with more dense breast tissue. And as I mentioned, large studies have shown that tomosynthesis increases both sensitivity and specificity of mammography, and it reduces recalls and increases cancer detection rate. So just a quick review. This is, if this were a 2D exam, the X-ray tube would be just in one point. There'd be a single millisecond exposure. This is the breast, this is the compression plate, and this is the image detector plate here. There would just be one view generated by this. With tomosynthesis, the X-ray tube moves across an arc while exposing multiple very low dose images. And again, the computer then kind of reconstructs this. This takes about nearly 4 seconds to do, and that's another reason why compression is very important, because 4 seconds, while it's very short, any movement that occurs during that will create additional artifacts. So again, unfortunately, breast compression is necessary. Yeah, I mentioned tomosynthesis definitely just helps us characterize masses, focal asymmetries, and architectural distortion. And just a word about breast density. All mammography reports come with a report as to what breast density you have. They range in 4 categories. We have fatty breast density here on the left, scattered breast density, and then heterogeneous, and then very dense breast tissue. These latter 2 categories, heterogeneous and dense, are both categorized as dense breast tissue. And you can see here on the left-hand side, we have a breast of fat density. And here on the right, we have a dense breast with dense breast tissue. This is a very small cancer that is clearly seen even without this red arrow pointing to it. It kind of stands out like a light bulb. Cancers present both as kind of soft tissue densities that are the same density as fibroglandular tissue, and they also, a significant portion of them also present with some calcifications. Calcification still can be seen in dense breast tissue, which is why we require a 2D image. In addition, here you can see on the right, there's a much larger cancer that's at the upper posterior glandular margin. If the circle weren't there, it'd probably be hard to see, except for it is a little bit more dense. And then the closer you look, has kind of an irregular spiculated margin. So, but that's the problem that tomosynthesis solves. Again, here's just real quick image examples of the improvements. Here's a 2D image. It's a craniocaudal view. An arrow is pointing to where the abnormality is. It's hard to say what is that. On just a 1 millimeter thick tomosynthesis view here with the circle, you see this. You can clearly see that there's a mass with an irregular spiculated margin. This is in the same breast, what we call the MLO, or medial lateral oblique view. Again, the arrow is pointing to where the abnormality is on the 2D. It's very difficult to pick that out. Again, on the 1 millimeter thick cut, you can clearly see there's a mass with a very suspicious irregular spiculated margin. Here's a cone down image of a 2D that shows just a vague abnormality. Here you can see with a thin cut, you can clearly define that this mass has a nice smooth margin to it. That has a more benign appearance. That doesn't mean that it's benign, but it it's one of the factors that we look at when we're evaluating exams as to whether this would require biopsy. And again, here's a pretty dramatic example, a cone down view. It'd be hard to pick out where an abnormality is. The 1 millimeter thick pictures show this spiculated mass that here, even with the arrows on, it's hard to see. So it is real. We find this all the time at the Breast Health Center by using 3D tomosynthesis that, cases that are very subtle, that sometimes there's the telltale signs on the 2D that after you see it on the 3D, it's like, oh, okay, you can pick it out. But the 3D makes it diagnosable. And the beauty about this exam, that new equipment that we have is that it does not increase the radiation exposure significantly compared to just a standard 2D exam. In order to be qualified as a low dose exam, the Mammography Quality Standard Act is one, lists a very large number of standards that we all adhere to, and it has to be under a 3 milligray exposure dose. A 2D digital exam exposure is 1.25 milligray. And as I mentioned, with the kind of standard resolution 3D, we do another exposure. This also produces a synthesized 2D view. However, the the synthesized 2D view does have, some more artifacts than we were happy with doing, and kind of felt that we wanted to keep the standard 2D, because we do detect additional abnormalities on a standard 2D image that are difficult to detect on 3D. So what that leads to is a dose that's getting up towards the upper limits. It's still considered low dose, but it's on the high side of that. With this new machine, the combination of both using the 3D tomosynthesis with a synthesized 2D view, it brings it back to about 1.4 milligray. So I think we can go more, in addition to the higher resolution of the images, more wholeheartedly embrace additional images. As you say, 3D does require additional images. We try to limit radiation exposure, and I feel that even having the 2 exams at one time is very well within very low dose, but some women do have concerns about that, and this will certainly alleviate some of those concerns. So behind the scenes, these are very large data sets with this new high-res 3D. And just suffice it to say that, this was an additional thing to have to purchase and expensive, but it's a computer processing that the algorithm kind of presents these large data sets in a way for the radiologist to be able to more efficiently and accurately, and still very accurately, evaluate, and find these small cancers. It also allows for compression, where these large data sets can flow across the network without jamming everything up, and also addressing the storage needs. So that's behind the scenes. Moving on to kind of the biopsy systems. Now, we do a lot of biopsies, as Ann mentioned. We do ultrasound-guided biopsies. We do MRI-guided biopsies. If we find an abnormality that is visible only on mammography, be that 2D or 3D tomosynthesis, we use a stereotactic / tomosynthesis guided biopsy. And we have the latest technology on both kind of a prone table that the patient would lay on. The breast would go through this hole in the table. Here you can see a compression plate, and then there's a needle system that is used to kind of sample the abnormality. We also have the same system in an upright. Laying prone is not necessarily some patients are unable to do that comfortably, and it's necessary to lie still during the exam. We have the same technology now in the upright system. And again, this is with the high resolution image detector. So finding these very subtle abnormalities, we'll be able to localize these and sample these without, because it's very, to be able to find something, but then to not be able to localize it to biopsy or for a surgical excision, it is very problematic. And in years prior, we would butt up against that on very subtle lesions. So, and then just finally, quickly wrapping up, something that will be kind of welcome for the patient is that with the aid of this particular device, it's called the Rivera biopsy system. What it is, it's the biopsy device and tubing and x-ray system all in one. If someone has a biopsy, we typically kind of do the setup with local anesthetic, take the samples, and then the samples need to be brought to a separate machine and then x-rayed. And now that goes very rapidly. We have a very high-end machine in the room that does that, but that takes sometimes a couple of minutes. And for somebody that's in the middle of a procedure, it seems much longer than a couple of minutes. This has new technology that as the sample is obtained, the specimen is drawn into a chamber and it's x-rayed real time. So we can see as the procedure is going on if we have the target of interest. So that will translate. And likewise, both of these machines also have improved mechanical features that do make it easier for previously some lesions that are very difficult to place to sample because they're either too close to the chest wall or the breast may be too thin, or a variety, there's a couple other reasons that we're able to overcome what those technology hurdles were. So anyway, that's just a brief overview. There's lots of new things in radiology, but this is kind of right at our doorstep. We get to start using this equipment, as I say, in January when we move in. So if we don't see you before, please come and visit us.
Great. Thank you so much, John. That was super helpful and comprehensive. We have several questions that have come up, and I'm going to try to do a couple of them that are related to imaging right now, and then we'll save some for the end just for the sake of getting onto some other talks. So one of the things I think that comes up a lot is, why do breast calcifications happen? And are calcifications in and of themselves concerning, and kind of what can you do to prevent it? Would you be willing to kind of give a brief discussion on calcifications? Because it is something that I hear a lot from patients.
Yes. Yeah. Well, one thing, most women do have calcifications in their breast. So that's calcifications can range from normal physiologic to kind of abnormal, kind of malignant calcifications. They are kind of the tip of the iceberg in a lot of screening detected cancers. They can account for between 12 to 40% of cancers that are detected on screening mammography. So they are something we're all of us breast imagers are very versed in looking for kind of the bad kind of calcifications. The other kind of calcifications, as I say, are very common. They're in physiologic. They can range from vascular calcifications, tending to be in older women, but to secretory calcifications that have nothing to do. They have no pre-malignant risk, to cysts that have no pre-malignant potential, developing calcification. So I can just say that a lot of times you'll get a normal report. They don't even mention calcification. We don't mention calcifications that we don't find suspicious, unless we're having to spend our time either magnifying them or kind of, doing more investigation on them. So I would say, so far, I don't know. I don't think there's something to get rid of calcifications once they develop. Physiological calcifications can kind of ebb and flow a little bit, but and just know that with mammography, we're very, if we're able to, when we call somebody back or when somebody comes for a diagnostic mammogram exam, and we do the magnification views to characterize the calcifications, we either categorize them as normal or benign, or indeterminate, or they could have a highly suspicious feature. So depending on what the pattern is, what their characteristics look like, sometimes they're just very clearly going to be associated with a cancer. So I don't know. That's long.
That was very helpful. And then the other question I think is a great one to answer as a group right now is suggestions for mammograms, specifically in women who have denser breasts. So kind of what would your screening recommendation be for someone who has dense breasts, maybe not taking family history into account, but just focusing on breast density?
Yes, I would say that, average risk, I think that, I think what I presented here earlier, that 3D tomosynthesis, I think first of all, annual mammography. There's a lot of discussion. I won't get into that about what the various guidelines are between the various societies, so far as whether you started screening at age 40, what frequency do you do every year, biannual, and then what age do you stop? So I would just say that here at the Breast Health Center, we conform to the American College of Radiology Society of Breast Imaging Society. And it's a conservative. We recommend starting average risk at screening at age 40 and annual exams. So that to begin with. And then if somebody does have if somebody has fatty or just scattered fibroglandular density, Even though tomosynthesis does add value in that, I don't think it's as important as somebody that has heterogeneous or very dense breast tissue. It's something that we see just every week, where there are lesions that we detect on 3D that we can characterize, and again, and even without this new technology, I think that's even with the standard tomosynthesis. The same goes for that. I would recommend tomosynthesis. And then I think somebody that's getting a higher risk, you're getting into whether you want to augment with screening breast ultrasound, screening breast MRI. Screening breast ultrasound is controversial. And again, that's another topic. The problem with screening breast ultrasound is that it does produce it does find additional cancers. However, it also produces a lot of false negative results, which we end up doing a lot of extra biopsies. And we always kind of want to balance the risk of having to do too many biopsies against, finding significant cancer lesions. Breast MRI, though, the evidence is out there that for somebody that is high risk, that would have dense breast tissue, I think that it would be to have a discussion with their physician about potentially adding annual screening breast MRI.
Great, thank you so much. So I think we'll move on now to Elizabeth Carte. As I mentioned, she is a genetic counselor at CPMC and is going to be focusing on genetic counseling and testing related to breast cancer. Thanks, Elizabeth.
Great, thank you. So as Dr. Peled just mentioned, I'm a cancer genetic counselor at CPMC. A lot of people wonder, what is a genetic counselor? What do you do? And I meet primarily with individuals that have been diagnosed with cancer to try to understand the cause, which can sometimes lead to different treatment options, different management plans after their cancer treatment ends, and better management of their family members. I also meet with people who have family members that have had cancer and are worried about their own cancer risks and what they should be doing to stay cancer-free. And we can go to the next slide. So today we'll start by discussing hereditary breast cancer, including some specific syndromes as well as genetic testing considerations. We'll also review familial breast cancer, what that means, who falls into that category, and then we'll finish by talking about what's new and on the horizon in the world of hereditary cancer. Next slide. So I'd like to get started with some vocab so we're all on the same page. Hereditary cancer means cancer that develops from an inherited genetic change called a mutation. And this is something that we can identify with current genetic testing methods. We do testing, it comes back positive. We're experiencing rapid growth in genetic testing. It's more accessible, it's more affordable, it's exciting, but I also think due to all that attention, there's become a misconception that cancer is either hereditary or not hereditary. But actually there are three categories. So there's hereditary, which we just mentioned, and that accounts for about 5 to 10% of breast cancers. But then there's familial, and that's where we see clusterings in families, yet we can't quite explain why. There could be environmental factors, there could be genes we haven't identified, it could be the combination of smaller genetic factors that we're just starting to understand, or more likely, it's all of that combined. And then lastly, there's sporadic cancer, and that's when cancer occurs in somebody who doesn't have a family history of cancer or an inherited genetic change or anything else that would have increased their risk. And so by and large, as you can see with this pie chart, the vast majority of cancers are sporadic and they occur in people who aren't flagged as high risk. Everyone has a risk for cancer, and that's why everyone should talk to their doctor about regular cancer screening, colonoscopies, mammograms, et cetera. But 20 to 30% of cancers do have a hereditary or a familial component. And we can use that knowledge to our benefit. We can use existing risk stratification tools, which aren't limited to genetic testing, we'll get to that, to find the individuals that could benefit from additional cancer screening and different medical interventions. So today I'm going to talk about the familial and the hereditary cancers, not because they're the most common or the most important, but because these are cancers that we can potentially prevent or detect earlier. Next slide. So hereditary cancers caused by genetic mutations, what does that mean? We all have lots of genes. We have over 20,000 genes, and they provide the instructions for everything we do, how we grow, how we develop, and a subset actually help protect us against developing cancer. So in these so-called cancer genes, we all have them. It's just some people will have a mutation or a change in them that keeps them from functioning the way they should, which puts us at a higher risk of developing certain kinds of cancer. Next slide. So when we're assessing if someone's at risk for hereditary cancer syndrome, we're looking for patterns in the family. The age of diagnosis can be a clue. Cancers that are diagnosed under 45 especially, but even under 50 if other relatives have been diagnosed with cancer. We look for specific types of cancer, male breast cancer, ovarian cancer, certain pancreatic and certain types of breast cancer like lobular or triple negative are a little bit more likely to be genetic. We know that individuals with certain ancestries are more likely to have a hereditary cancer syndrome as well. Ashkenazi Jewish is one group that we hear about, but there are founder mutations in other populations as well. That's a specific mutation that's more common to certain populations. And then seeing multiple cancers in a family, especially if they're diagnosed at younger ages, is a red flag. And then obviously if there's a known genetic mutation in the family. So what are these syndromes? We can go to the next slide. The most common hereditary breast cancer syndrome comes from a mutation in one of the BRCA genes. There are two of them. Some people call them BRCA. It just stands for breast cancer gene 1, breast cancer gene 2. When people are familiar with hereditary cancer genes, this is typically the one that they've heard of. And for good reason. It was the first gene that was identified back in the 90s to be associated with breast cancer. It's still one of the most common genes identified in both men and women with breast cancer, and it's one of the higher risk genes. So looking at this little chart, you can see that a woman with a mutation in one of the BRCA genes has around a 60% lifetime chance of developing breast cancer. We just heard that the average woman has 12%, 1 in 8, so obviously that's quite elevated. They have an increased chance of developing another breast cancer and an increased risk of ovarian cancer as well. Men also have increased cancer risks for breast and prostate. And then depending on family history, we can see increased rates of pancreatic and melanoma too. BRCA has also received a lot of media attention. So going to the next slide, even back in 2008, we first started hearing about this. Christina Applegate had a double mastectomy when she had breast cancer at 37. She was found to have a BRCA mutation. The next slide, Angelina Jolie also decided to, she didn't have breast cancer, but she decided to have a bilateral mastectomy prophylactically because she had a BRCA mutation in a family history. And then next slide, just last October, Beyonce's dad came forward and shared that he has a BRCA mutation and that more men should be thinking about what this mutation could mean for them. Next slide. So BRCA is a big gene that we hear a lot about, but it isn't the only one. And with advances in technology, we can test multiple genes at the same time for relatively the same price and pretty much with the same turnaround time. So we try to categorize the genes in different ways to help people decide what testing they want to do. We're obviously not going to go through all 84 genes. That's how many we can test in a clinical setting right now. And so ways we do that is we can think about the cancers they're associated with, the degree of cancer risk that they provide, and then based on how they would change someone's screening plan. So looking at high-risk genes, this means there's a mutation in one of these genes would increase someone's likelihood to develop cancer significantly, so in the 40 to 60% lifetime range. The takeaway from this slide, though, is that similar to BRCA, even though these are, quote-unquote breast cancer genes, they're also associated with other forms of cancer. Next slide. So here are a few more, just trying to show you how many genes we have. These are moderate risk genes, so cancer risks are going to be around 20 to 40%. And again, you see that other cancer types are associated with these genes. And then the next slide shows that we have other types of genes. We have low risk and we have preliminary evidence genes. And so low risk, they've been linked to hereditary cancer, but we might not know just how so. So I could say there's an increased risk of this type of cancer. And then preliminary evidence genes, that's where the association is speculative and may prove to be clinically useful in the future, but right now we just don't have the data to suggest or to support that. So thinking about these genes, why learn about hereditary cancer risks? People wonder, isn't that just going to lead to more anxiety or worry? And maybe for some, and that's why testing can be a personal decision, but the goal is that it helps us identify high-risk individuals and allows for earlier detection and the implementation of different risk reduction strategies. So looking at BRCA, there's a lot we can do with this information. It's recommended that women begin breast cancer screening much earlier than the average risk woman. Makes sense given that the cancer risks are higher. They can consider surgical interventions to reduce the likelihood of breast or ovarian cancer too. Men will often develop a specialized care plan as well. So some will be recommended to have a mammogram. Sometimes we'll recommend additional prostate cancer screening. And then for both men and women, depending on family history, pancreatic cancer screening and melanoma screening might also be recommended. And so I think a big reason why these two genes have been given so much attention is also because there's so much you can do with it. Next slide. So going back to all of those genes, the management is going to be diverse because the degree of risk varies based on the gene and the types of cancers associated vary. And so it really can be individualized to the individual person. So screening sometimes might include self-exams, clinical exams, blood or urine tests. It can include different imaging modalities, some of which we just heard about, which can begin at different ages and on different intervals. Medications can sometimes be prescribed to help reduce risk, and all the way to preventative surgeries. And again, the goal is just early detection and prevention. So yeah, we can have the next slide. So the cancer genes, they can have a real impact and they can help keep people healthy, but the decision to have testing isn't always straightforward. There are some clinical considerations, of course. So which genes should we test? We can, as I mentioned, routinely test up to 84, but we don't have screening plans or they're proven to be effective for all of these genes. Yeah, so some people don't want information that can't be used. We think about what types of results we're going to get. We often get uncertain results. I'm not going to get into that today just for time, but that's a possibility. We think about how the results are going to change someone's management. We don't want to just do something because we can. We want it to be impactful. And then we think about who should we test in the family. It's always best to test someone who's had cancer, but that's not always possible. So we work with what we have. In addition to those clinical considerations, there are psychosocial implications too. So how will you feel after learning about hereditary cancer risks? How does signing up for additional screening, how's that going to feel moving forward? Hereditary cancer testing often brings up emotions of personal experiences with cancer or even losing loved ones to cancer, which can be a lot to unpack. And then if positive, what do we do with that? How are we going to share the information with relatives? How can we use this, moving forward for, the greater family? Legal considerations often come up and patients wonder about insurance coverage and cost and genetic discrimination. Luckily, most insurance companies cover testing when it's appropriate. When they don't, there are financial assistance programs that are usually able to help most patients afford the testing. And then regarding genetic discrimination, in 2008, there was a law that was passed that protects people from employment and health insurance discrimination, which is really great. Next slide. So let's say you made the decision to have testing, results were negative. Where do you go now? So remember, looking at this hereditary piece, the single gene causes of breast cancer that we just went over, they're limited, and it's really only part of the story. About 15 to 20% of the time, we test people with a family history of cancer or even a personal history, and the results are negative. Is it high risk still? Looking at the next slide, here's one previous, please. Yes. This is the hypothetical family. This is what we look at in genetics. It's called a pedigree. So this is the family. Each row is going to represent a generation, and circles are the females and squares are the males. And so my patient is on the third row. She's the one with the little arrow. She's 50, and she is newly diagnosed with breast cancer. And looking at this pedigree, you can see that her family history is significant for an older sister who had breast cancer at 48, and a maternal aunt who had breast cancer at 43. So my patient did testing and the results were negative. So this is reassuring and suggests that her cancer is not due to a single gene. So it's not the hereditary form, at least not what we've discovered so far. And it also suggests she doesn't have an increased risk for another type of cancer like ovarian or colon. But what about her other female relatives? Should they be doing more breast cancer screening? She has a daughter who's in her 20s, a niece in her 30s, 2 other sisters. And so it depends. First question I'd ask, did her aunt and sister, the 2 who had cancer, did they do testing? It's possible that my patient's cancer was sporadic, that third category, which just means, not due to any of these factors we know about. And her sister and aunt had a hereditary cancer syndrome that my patient didn't inherit. That happens more often than you'd think. And then going to the next slide, I'd look at, there are other factors that influence breast cancer risk too. So I'm always telling my patients genetics is just one piece of the cancer puzzle. Some of the others are what's the extended family history, how old are you, what's your weight, when did you have your first child, breast density as was just discussed, and then have you had abnormal breast biopsies in the past? And there are many others that factor into this. But we can use all of these factors, including the negative genetic testing, to perform a more personalized breast cancer risk assessment and determine who's expected to benefit from increased screening. And that's why even if a cancer in your family isn't hereditary or due to an inherited genetic mutation, it's still important to discuss your family history with your doctor to see if there are additional options that could be beneficial for you. So next slide. So looking forward, what's on the horizon? Gosh, there's so much. We're still discovering new genes associated with hereditary cancer risk. And even for those genes that we have discovered, we're still learning more about what those cancers are that are associated. Once a mutation's been identified, we're still learning how to best manage individuals with the hereditary cancer syndromes. Management recommendations are changing every couple months right now. We're looking at new ways to personalize someone's risk for developing cancer too. So I just mentioned that cancer or that genetics is only one piece of the puzzle. So more sophisticated tools are being developed that incorporate additional factors, such as polygenic risk scores, which are how smaller genetic factors work together to influence risk. Ways to incorporate negative multi-gene panels into that risk assessment. Typically, we just look at BRCA. And then ways to incorporate more family history and other factors. There's new testing technology as well that's coming out. So typically when genetic testing is performed, we're just doing it on DNA, but we can now test RNA, which gives us a better idea of how mutation will affect the gene function. So just real quick, your DNA turns into RNA, which turns into your protein, and the proteins are what help protect us against cancer. So the RNA is a little bit closer to the protein and the effect in the body. There are also, more options for paired germline and somatic testing. So germline is what we've been talking about. It's our normal cells, the ones that are inherited from our parents. Somatic is the tumor cells. But by combining the two, we can look for the genetic drivers of cancer, which could influence treatment decisions, as well as those inherited mutations that could be relevant for the immediate treatment decision, but also for developing the long-term screening plan after treatment and for the family at the same time. And then lastly, not the last, but the last that I'll focus on right now is looking at novel treatments. Go back to the last slide real fast. So we're looking at developing more targeted therapies which target the molecular or the genetic drivers of cancer, and the promise is that they'll be easier on the body and lead to better outcomes. So now we can go to conclusion to end my talk. So genetic counseling is for those who've had cancer. It's for those who currently have cancer, who have had it in the past, and for those who have family members that have had cancer. Most cancer, again, is not due to an underlying inherited genetic mutation, that hereditary form, but as many as 20 to 30% of cancers have a hereditary familial component, and so these are the ones that we can get ahead on. And to that point, a genetics evaluation can help identify individuals that are expected to benefit from additional screening or personalized management plans, as well as those who likely won't. So maybe they didn't inherit the family mutation. And lastly, cancer genetics, just like everything in medicine and cancer, is quickly and frequently evolving. So I expect over time we'll have better technology for detecting mutations, more information about inherited cancer risks, and better ways to prevent and treat these cancers. So stay tuned for more. Thank you.
Thank you so much, Elizabeth. That was excellent. I learned so much. So we really appreciate that. I'm going to save some of the questions till the end just for the sake of time. So I think we'll move on to Dr. Edquilang talking about breast surgery.
So my name is Joanne Edquilang. I'm one of the breast surgeons. Thank you for having me. I'm very pleased to be able to talk about what we do as breast surgeons and what breast surgery looks like in 2020. So I thought we'd start with, what does a breast surgeon do? We primarily see patients with breast cancer, but as breast specialists, we offer comprehensive breast care and often see patients who have a higher risk of breast cancer, including the patients that we just heard about with either a family history or a genetic mutation. Also patients with benign breast tumors, patients with breastfeeding concerns, patients with breast infections, and even patients who have chronic breast pain. Oh, I'm sorry, it's not moving forward. There we go. So we'll focus today on the patient's journey with breast cancer, though. And so when in her journey does the patient typically meet her breast surgeon? And most commonly, we meet our patients after a referral from our radiology colleagues, after an abnormal mammogram, or after a patient feels a breast lump herself on self-exam, and also those who have genetic mutations. But let's take a step back and look at the bigger picture of a patient's breast cancer journey and where breast surgery fits in. Here you see what a typical journey of a breast cancer patient looks like, and when she meets various members of the team that takes care of her. So starting off at the beginning of the journey, thankfully through the life-saving effort of screening mammograms, we see a lot of patients very early in their disease after an abnormal finding on her yearly mammogram. Patients are then called back to perform what we call a diagnostic mammogram, which is a closer look and additional views by the radiologist. And these mammograms are sometimes accompanied by an ultrasound or an MRI to take a closer look at the area of concern. And at this point, they're referred for a needle biopsy, and the breast pathologist then looks at the biopsy and makes the diagnosis of breast cancer. In early breast cancer, the next person the patient usually meets is the breast surgeon. And the breast surgeon works with the team, the radiologist, the pathologist, the medical oncologist, and radiation oncologist, often referred to as the tumor board. And together we recommend a treatment plan. And if the patient gets surgery first, she then continues her treatment with the medical oncologist or the radiation oncologist after surgery, depending on what type of breast cancer she has. But let's take a closer look at breast surgery and what does breast surgery look like in 2020. Over the past 50 years, there's been a paradigm shift in our understanding of breast cancer, and this change in the understanding of how it spreads has really led to less surgery and an approach that's more patient-centered, where the focus is patient education and empowering women to really make the decisions about their own treatment. And that's what we call shared decision-making. And we used to believe that more surgery was always better for patients. These pictures are from old textbooks describing what we call the Halsted radical mastectomy, removing the entire breast, all the chest wall muscles, and yes, even sometimes the ribs, as well as all the lymph nodes under the arm, which thankfully we rarely see anymore. And I don't show this to shock anyone, but just to show how far we've come from the disfiguring, debilitating mastectomies of the past. And then after all that, no reconstruction was available for these patients at that time. What we found in very large clinical trials was that patients treated with lumpectomy, or removal of part of the breast, not the whole breast, and radiation therapy had the same survival as patients treated with mastectomy. So in other words, patients who had mastectomies did not live any longer, even though they had the larger, more invasive surgery. So now most patients can choose between having a lumpectomy or a mastectomy. And there may be some patients with larger tumors or who have genetic mutations for whom mastectomy is still recommended. But for most patients with smaller early stage tumors, they can safely save their breasts. And checking the axillary lymph nodes under the arm is an important part of breast cancer staging. If cancer is trying to spread outside of the breast to the other parts of the body, the lymph nodes in the axilla are usually the first place outside of the breast that the cancer can be detected. And so there's two types of surgery that can be used to check for cancer in the lymph nodes: an axillary dissection, which is removal of all of the lymph nodes, or a sentinel lymph node biopsy. And axillary dissections are rather uncommon now, and but before in the 1990s, patients with cancer routinely got dissections. And when a larger number of lymph nodes is removed from the axilla or the underarm, the patient is at higher risk of developing chronic arm swelling, otherwise known as lymphedema. By the late 1990s, the technique of sentinel lymph node biopsy was adopted for most patients who didn't have nodes that we could feel. And sentinel lymph node biopsy involves injecting a small amount of blue dye or radioactive tracer into the breast. The dye is then picked up by the lymph channels in the breast, and then it's trapped in the first few lymph nodes in the axilla. And those are the ones that we remove. And these so-called sentinel lymph nodes are the first few lymph nodes and can give us an accurate kind of picture of the status of the rest of the lymph nodes without having to remove all the lymph nodes and causing lymphedema. We've also found that we can safely omit lymph node surgery altogether in some patients. Older women who have breast cancers that are hormone sensitive and who also don't have abnormal lymph nodes that we can feel can safely avoid lymph node surgery altogether. But regardless of what type of surgery a woman chooses to have, there have been great advances in improving the cosmetic outcome for patients after surgery. The term oncoplastics is something that you may have heard about, and it's a fancy way of saying that the breast surgeon can rearrange the surrounding tissue to fill that defect that's caused by removing the tumor in a lumpectomy. And so after removing the tumor, there's going to be an empty cavity. And if the surrounding tissue isn't rearranged, then the breast tissue can develop a dent. And we try very hard to hide our incisions along the areola or under the breast, and then we rearrange the tissue to fill that defect. In these pictures, you can see that the incisions are well hidden and the contour of the breast is well preserved. In addition to tissue rearrangement or oncoplastic closure, there are implantable devices now that can help fill the defect and act as a scaffold for your remaining breast tissue to heal into the defect caused by the lumpectomy. And so you can see that these devices have titanium clips around the devices, and you can see on the mammogram that we can see the clips. These clips serve as markers for our radiation oncology colleagues to give targeted radiation to the area where the cancer was. So patients undergoing mastectomy nowadays can also have improved cosmetic results with the nipple-sparing mastectomy technique. And here are a few photos of some of our patients who have had nipple-sparing mastectomy on one side, and you can kind of compare the reconstructed breast to the other side and appreciate how nipple sparing can really achieve a natural looking reconstruction, because the entire skin envelope, including the patient's own nipple and areola, are preserved. And nipple sparing can be possible for many patients. We use incisions that are often hidden under the breast right here, remove all of the breast tissue inside, and then the plastic surgeon can then reconstruct the breast with an implant or the patient's own tissue, usually from the abdominal wall. And so overall, there are many options when it comes to breast surgery, and developing a treatment plan that is important. It's an important process between the surgeon and the patient. And our goal is to actually help you and empower you. And together as a team, we can identify your goals, what you value, and make a treatment plan together. And that's really what shared decision-making is. Breast cancer care is a model for that, I think, because we know that all women are not the same. What's important to one woman may not be important at all to another. And so we're really here for you. And these are some members of our team, Dr. Grissom and Dr. Lee Chara, as well as our advanced practice providers who we work very closely with, Sarah McFadden, who's a PA, and Christine Kim, who's a nurse practitioner. We offer comprehensive breast cancer care, but we're also very happy to help with patients in our high risk program who are for patients who have a family history or who have a genetic mutation who are at increased risk of developing breast cancer. And also those who are followed kind of afterward into survivorship. And so thank you very much for your attention.
Thank you so much for that. It's really amazing to see how far we've come in breast surgery, and I love the focus on shared decision making, which has become so important. So I think we will move on to Dr. Stephanie Jeske, who will be coming to us with a medical oncology perspective. Thank you, Stephanie.
Thank you. Thank you for the invite, and thank you for everybody making it this far. I'm impressed anybody's left. Well done. I am here to talk a little bit about medical oncology and breast cancer and some of the innovations we've seen there. So the process of treating breast cancer, we've heard about diagnosis at our state-of-the-art breast imaging center. We've heard about genetics and the assessment. We get to sort of assess patients' risk. We've heard about the innovations in surgical resection. And then what I'm tasked with for my patients is to try to prevent recurrence. To prevent recurrence, we know the surgeons are fantastic at eliminating the cancer. Then it's our job to try to prevent the cancer from coming back. So as Joe mentioned, radiation therapy can be directed to the breast to prevent a local recurrence, but we need medical therapies to prevent distant recurrence, or recurrence of the cancer somewhere else in the body. Since we can't see those invisible cells that may have floated out through the lymph system or the bloodstream, we have to use a medicine that can go find those cells and kill them. So we know that different kinds of breast cancer are very different from each other. So there are receptors on the surface of cancer cells, as demonstrated here, and different breast cancer cells have different receptors. And depending on what kind of receptor you have on the surface of your breast cancer cells, you have options for targeting that receptor and, by extension, blocking the cell from being able to grow and to divide. And so we know that when we look at all breast cancers, there are 3 receptors that are really important. There are 2 hormone receptors, estrogen and progesterone. And we know that about 75% of women have hormone-positive breast cancer. There's also a 3rd kind of receptor with a funny name called HER2/neu. And some of those hormone receptor positive cancers are also HER2/neu positive, and some hormone receptor negative breast cancers are HER2/neu positive. And then there is the 3rd category, which are the triple negative breast cancers. And we call them triple negative because they don't have estrogen, progesterone, or HER2/neu receptors. And so we have to find different ways to target and kill those cells. Some of the systemic therapies we use for breast cancer are chemotherapy. which is strong IV medicine that goes and kills cells in active division. We use hormone therapy, or technically it's hormone blocking therapy, to try to take advantage of those hormone sensitive cancers and kill them at their sort of Achilles heel. Then we also have various targeted therapies, and now we even have immunotherapy, boosting your own immune system to try to go fight cancer, because of course all cancer truly is a failure of your immune system. So chemotherapy, the first thing I think everybody thinks when they are given a cancer diagnosis, or many people think, is, am I going to need chemotherapy? Because chemotherapy is obviously life-altering temporarily, and for many patients long-term, because of effects that never go away. So we've always tried to guess, but it's been a guess, an educated guess, but a guess at who needs the chemotherapy and who doesn't in breast cancer. And some of the features we take into account are things like, are they estrogen sensitive? Are they HER2 positive? Is the woman with the breast cancer younger? Younger women tend to be more responsive to chemotherapy, older women less. What grade is the cancer? And so putting these all together, we've sort of been tasked as medical oncologists to come up with a recommendation just based on all this circumstantial evidence. But no longer. Now we can do genetic testing of the cancer cells. One such test is Oncotype, as imaged here. And this is a genetic test of the cancer cells to understand, are these cancer cells sensitive to chemotherapy? So since this kind of, there's another test called MammaPrint, since these kinds of genetic testing platforms have come out, we have spared many, many women from needing chemotherapy, because we're much more able to identify and personalize the cancers that are responsive to chemotherapy, where we need the chemotherapy, and the cancers that are not, and where we can skip it. We also know that one of the big issues with getting chemotherapy is it makes you lose your hair. You go into a breast cancer diagnosis looking very healthy, even though you have cancer. But when you go through chemotherapy and lose your hair, you do not look healthy. You look like a cancer patient, and it's a huge emotional weight for people. So now, thankfully, we have some options for cold cap therapy. This is the Penguin cold cap. We also use DignaCap, and we essentially place the caps on just before, during, and all after the chemotherapy is being infused, to simply cool the scalp, to reduce the blood flow to the hair while the chemotherapy is at its highest concentration in the bloodstream, and try to prevent the hair loss. And it has variable results depending on the person, but some people have really dramatic responses, and like this woman did. So hormone therapy, 75% of all breast cancers are hormone sensitive, estrogen and progesterone, the two female hormones. The standard length of hormone treatment was always 5 years, but there are some new data that suggests that 10 years might be better than 5. So how do we know who needs 10 years and who needs 5? Just like the Oncotype, there's now a genetic test of the cancer cells, again, called the Breast Cancer Index. The Breast Cancer Index gives us 2 predictions. It predicts what the likelihood of benefit for doing an extended therapy of 10 years instead of 5 would be for the patient. And it also gives an interesting evaluation of prognosis. So it gives you the risk of a late recurrence, a recurrence in the years 5 to 10 after your diagnosis. We often think about recurrence in the early years, but Breast Cancer Index is a very personalized test looking at what your recurrence risk is later. We have new hormone therapies too. We have CDK4/6 inhibitors, as I show here, Verzenio, Ibrance, Kisqali, and these are sort of hormone boosters that help boost traditional hormone therapies. They interrupt the growth of cancer cells, and they help hormone therapies to work both better and for far longer than they could by themselves. What about the most dangerous breast cancers, like the HER2 positive breast cancers and the triple negative cancers? These were always the cancers medical oncologists feared the most because we had the least options for treating them, and they were the most aggressive cancers. That has changed, thankfully. So we almost hope for HER2 positive studies these days because we have so many HER2 positive cancer treatments. The original cancer therapy that was developed to target HER2 was Herceptin. And then its cousin Perjeta came out, both targeting the HER2 receptor on the surface of cells. Then Genentech, which developed both of those, came up with a clever idea, and they developed Kadcyla here in the middle, where you take that same linker that links to the HER2 receptor on the surface of cells, and you attach it to some very, very toxic chemotherapy that is too toxic to be given systemically. The body can't handle it. But what it does is it directly delivers that chemotherapy into the center of the cell, and like a smart bomb, kills the cell from the inside. And then this newest treatment, just FDA approved a few months ago, tucatinib, is also a HER2 targeted drug. This one developed in Seattle, but it's oral therapy. It's the first of all of them to be available orally without not having to come for IV therapy. And it also works particularly well when the cancer is spread to the brain, which is a unique advantage of this one over the others. So we have a lot of better options than we ever had before. The other kind of cancer we worry about are these triple negative cancers, because all these receptors that we have been targeting with all these other treatments are not there. So traditionally, chemotherapy was the only treatment we had for triple negative breast cancer, but now we have new options. We're finding immunotherapies are helpful for some triple negative breast cancers. They essentially take the brakes off of your immune system and then let the immune system run more rampant, and try to encourage the immune system then to go out and find cancer cells and use your own body to kill the cancer. We also now have PARP inhibitors, especially for cancers that develop because of a BRCA mutation. These cancers are uniquely sensitive to PARP inhibitors, which are oral therapies that take advantage of that change in the genetic code and can help treat them. So in conclusion, we have a far more personalized approach to treatment these days. It's not one size fits all. We do a much more comprehensive evaluation of the tumor, the patients, the genetics, and develop a much more individualized treatment plan for each individual going through this journey. We have a lot of new treatment options, thankfully, and there are more coming at all times. And we have far better rates of cure for breast cancer, and especially in the cancers that used to be the most frightening. So thank you so much for your time and for the invitation. And I appreciate the opportunity to speak in Breast Cancer Awareness Month.
Thank you so much, Stephanie. That was excellent. I would love to move on in the last few minutes we have, and thank you all to all of you who've stuck with us through this whole hour and a half. But we had a couple questions, Stephanie, that I think would be great for you. The first one was about postmenopausal use of low-dose tamoxifen for something like ADH, ALH, and potentially hyperplasia.
That's another new thing that came out last year. So there was an Italian study that looked to see, we often use these hormone therapies for treating breast cancer, but these hormone therapies can also prevent cancer from developing in people who are at higher risk for a breast cancer. And so there was traditionally, we've always treated those patients with the same doses we treat patients who've had breast cancer. But nowadays, there's a trial that showed in Italy that perhaps a quarter of the dose of tamoxifen is sufficient to accomplish the same thing. The highest level data for this is not yet available. They did a single arm trial. So they did a trial where everyone just got the low dose. And then they compared how they would be predicted to do compared to how they actually did, what the rates of cancer development were compared to what they were predicted to be. So that's not quite the highest level evidence, but it's pretty compelling data. And we're treating a lot of people with low dose tamoxifen now instead of the full dose, or aromatase inhibitors at the full dose. There is a trial going on right now to compare both arms. So we'll ultimately have the highest level data, but even in the absence of that, we are using low dose therapy. In many situations, being able to take a low dose tamoxifen is kind of the only option, because sometimes these therapies are very toxic and people cannot deal with the side effects from them. And so sometimes this gives people who didn't have an option otherwise an option, which was exciting. We're not using low-dose therapy yet in treating invasive cancer. It's only in prevention, unfortunately.
Yeah, I think that's really important to include that because with side effects, I'm sure a lot of people would love to be on low-dose tamoxifen for everything, but maybe we'll get to the point where
I'd love to give them low-dose for everything.
But maybe we'll get more tailored therapy like we have with some other things. Another, I think, really key question that I see come up with our patients a lot is long-term peripheral neuropathy.
No.
So, and side effects of chemotherapy, unfortunately, that's one of the ones we all, feel really sorry about and really dread when those things come up. Anything that has come up or any advancements that you found that have worked for your patients for peripheral neuropathy?
We try to take a really integrative approach for dealing with neuropathy. Obviously, preventing it from happening in the first place is the best solution for peripheral neuropathy than trying to deal with it after it's happened. So we watch incredibly closely for it. We also give our patients or encourage our patients to take some vitamin supplements. L-glutamine and vitamin B6 can be very good in preventing peripheral neuropathy. Acupuncture has some data too to support patients in lowering their rates of development of peripheral neuropathy. But unfortunately, once you've developed neuropathy, sometimes it is permanent. About a third of people, it goes away completely. About a third, it gets better, but doesn't completely go away. And a third never improve at all. And there is not a solution to fix that years down the road. That is one of the many things that people struggle with long-term after chemotherapy.
Great, thank you for that. It's nice to know at least there are some things we can do to help with prevention. Elizabeth, I think this is a great question. Again, something that comes up a lot, which is changes in genetic screening in the last 5 years. And the way that I think about this is you see people who come in who may have had genetic testing in the past, maybe in 2010, 2013, and now maybe they have a new breast cancer diagnosis or a new family member. How do you help those people in terms of thinking about should they have repeat genetic testing or how do you advise them? Oh, you're muted right now, Elizabeth. Thanks.
Okay, can you hear me now?
Can.
Great. So this is a big question and it always comes up. And even when people have negative results and they're leaving, they say, well, when should I come back? How do I know when I can do testing again? And I think, Dr. Peled, what you just mentioned is when there's a change in the family history, that's always a good time to touch base again. If there's, hopefully it doesn't happen, but if there's a new cancer diagnosis in that patient or in a family member, that's a good time to see what's changed. I also think just every couple years, it makes sense you can just ask your primary care, you can ask your surgeon or oncologist, whoever you're working with, if they're aware of any changes. And touch base with us again. I saw one of the questions in the Q&A was what's happened in 5 years. And in 5 years, you probably would have just been tested for one gene and now we can do 84. So clearly that's a lot that's changed in 5 years. So every couple years or when something changes in the family.
Perfect, thanks. And I think, for those of us who see breast cancer patients on our screening, we have found several kind of unique mutations that come up in patients that they would never have found, as you said, in the past. And so now it's kind of what do we do with that information? A lot of them aren't even associated necessarily with breast cancer risk. So I'm sure you see this as well. I personally feel like knowledge is power. And so having that information, regardless of what you do with it, is hugely helpful. But I can see for some people, it's a little overwhelming to some extent in some cases to have all of that information and know what to do next with it.
Yeah. And I think, if you get tested in a place where you're connected to other providers, sometimes it's a watch and wait. That information's in your chart. When we know more, you get that. Others, maybe there's a specialist somewhere who's working on it and you can get connected to research. So options are available.
Perfect. Thank you. I think this would be a good one, Dr. Edquilang, if you can answer. It's a question about pain going away after breast cancer treatment. I know that's a very large kind of nuanced topic, but maybe just general thoughts about how you think about it with your patients and if they're having radiation and things like that.
Yeah, I think it really depends on the kind of surgery that the patient has, and then the type of reconstruction, and also kind of the further treatment afterward. And so I think it's kind of a hard question to answer, but But I think it's great that that we can offer less and less surgery. I know that maybe you can talk a little bit about Dr. Peled about your experience with reconstruction, but from our standpoint with lumpectomies and with breast conservation, the great majority of patients are able to have small surgeries, less surgeries, come and go surgeries. And so I think with that kind of development over time and doing less and less surgery is great. I always think, you know, breast surgeons are always trying to put ourselves out of business. And so I think it's great.
I love that. I feel exactly the same way. I love telling people they don't need surgery, and I hope we continue to keep doing less in the future. And I think you're spot on. I think with lumpectomies, we really have an opportunity to have kind of minimal impact on people's lives short term. I will say, and it's a little unfair because we don't have any radiation oncologists on the panel, but I will say that we do see some of the long-term effects, I think, of radiation. It really does take a long time for that to get better. And I think it's important for people to know that there may be long-term impact. And a lot of times people worry about breast pain as a symptom of recurrence. I think that's a very real concern. And certainly what I tell my patients is if you have new symptoms, come in. We want to see you. Don't be home worrying. But most of the time that longer term pain, it does get better, but that's kind of part of the healing process. All right, Stephanie, for you. All right, is there an alternative to tamoxifen for premenopausal women? I'm 38 years old and was just diagnosed with a local recurrence. One lymph node only. My doctor is recommending possible hysterectomy. Tamoxifen side effects were harsh. Possible shots to put into menopause, and this chemo recommended treatment for ER positive, HER2 negative. I did 4 rounds the first time 5 years ago. So I know this is a lot of information. This is almost like a tumor board question we would have, but maybe if there's a way to give a couple lines on the answer to that, that would be great.
So yes, the treatment option for other than tamoxifen for premenopausal women is the shots. Essentially, the shots are ovarian suppression. So they put your ovaries into menopause. You essentially become a menopausal person, and then you can use the treatments that we have for postmenopausal women, like the aromatase inhibitors. They're no picnic either, though. Tamoxifan's tough. Ovarian suppression and aromatase inhibitors are tough. It's all tough therapy. And I think, especially for my patients in their 30s, it's particularly challenging. Your body is nowhere near ready to be in menopause and nowhere near ready to deal with these low estrogen states. And it can be incredibly difficult. So I think other supportive measures are really important. Things like an integrative approach, using acupuncture for joint pains, using other pharmacologic therapies for hot flashes and night sweats and that sort of thing to try to make it more manageable. And then often in lymph node positive, HER2 positive or HER2 negative, but estrogen positive cancers, we'd often do one of those genetic studies, such as an oncotype or a mammoprint, to help gauge whether chemotherapy is necessary, especially for a local recurrence, which we would consider more a failure of surgery or radiation therapy. Do we really need to go that extra step and do all of that additional chemotherapy? Those tests are meant to help answer that question. Will it help?
Great, thank you. And I love that you brought up talking about and seeking advice on side effects of treatment. It always makes me so sad to see people who come in and they have significant side effects from treatment and they've never brought it up with their medical oncologist. And so they didn't know for years that they, you know, not that we're always perfect at fixing those, but at least there are options. So I think it's great for people to know if you are having side effects of any kind of therapy, you know, ask your care provider if there are options for you. So I want to be cognizant of time. It is 6:03, but I can't thank all of you enough as panelists for joining us. You guys did an excellent job. I think this was really helpful. I learned a lot. And to everyone for joining, thank you so much. If you have any other questions, Twin will follow up, as she mentioned. And certainly all of us are happy to answer any additional questions and have more resources through the Breast Health Center in our program. Twin, anything else?
Yeah. Thank you so much, everyone. And thank you, our audience, for joining us for this wonderful series of presentations. We hope that everyone enjoyed learning from all these different experts in breast cancer care and community Health Resource Center also has plenty more health presentations like this coming up. When you take the survey, opt in for our mailing list and we'll make sure to remind you of those. And then you'll also be receiving an email after this tomorrow, likely containing a links for our video recording today and helpful links from our presenters today too. And if you guys don't have anything else to add, I will sign us out.
Thanks for your help, Twin. Thanks, everyone.
Thank you so much for joining.
You're all good health.
Thank you.